Hi everybody, I'm a research 4 at Walter Reed, and as we get into this, you'll hear threads of the work by Colonel Mary Edwards from the Army. Dr. Hetz and some of the discussion at lunch proved a great setup man for some of the things I'm going to talk about, specifically here for the Navy work. Secretary Mattis hasn't seen my slides either, and Colonel Ritter, one of our authors, received some research support not related to any of this. So as the people in this room know, the ship's surgeon is a pretty big deal, at least in the Navy. It seems like a great opportunity as you come out of residency. You get a great worldwide deployability. You get a cool mobile office, with one of the problems being your mobile office may be about there. And so you're thousands of miles from your nearest medevac capability. Depending on your operations status, you may have limited communications. And by the way, you're also the urologist, the neurosurgeon, the OBGYN, and similar to our rural surgery colleagues that have been discussed a couple times today, if anything happens, you are there alone and unafraid in the middle of the ocean. So as several discussions have talked about today, we started thinking, are we preparing specifically the young deployed Navy general surgeon for their first role at sea? So with this question, we decided to do an educational needs assessment. So no hypothesis with this, just kind of exploring what data was out there. And we decided we had to answer two questions to get to our primary clinical outcome, which was really, what is going on with the float surgery right now? Meaning, has it changed over the last 30 years as training has changed? And for this, we kind of arbitrarily chose the integration of laparoscopy at sea around the year 97 to 2000 as our delineation. Not because laparoscopy itself has any specific impact on what we do at sea, but just as the most common time frame delineator from what some of the more senior people in the room may see as what we used to do versus what we're doing now. And then the second question is, are the general surgery graduates that are going to sea right now prepared for that? And we'll talk about their experience here in just a couple moments. So the first of two questions we had to answer was, has a float surgery really changed from when some of the captains or some of the retired folks that are here in the room went aboard their first ship? So we started to look at the case logs, and is there any difference, trying to look at a very basic level. So we looked at the DoD registry for cases performed at sea, except that there isn't one. So we started talking to some of the fleet surgeons to get their registries and find out what was done aboard ships in the different AORs, except that doesn't exist either. And so we went to a literature review, which at least in the 1990s, kind of this pre-laparoscopy time frame, had 6 to 8 different literature, different logs published, one of them by Fontana and Captain Liston from our institution. And then in the 2000s, we were able to get a few more case logs from just personal emails and a couple other articles that are out there, and ended up about tripling the number of logs that are at least in the published literature. So hopefully adding to the body of work for this. So once we got our case logs together, because all the deployments were different, we normalized it to a 7-month deployment, which we thought was a reasonable comparison for the Navy's paradigm. And then as we went through, we noticed that there were groups of cases that were easily compared among all these different case logs. So you see on the bottom right there, the groups that we started comparing to each other. Because as you'll see later, some of the individual cases were such a low incidence that comparing individual cases just wasn't getting us any data. So has the float surgery changed? We compiled around 24 different deployed case logs totaling more than 1,300 procedures from the mid-1990s through 2017. And what we found out is two answers. One of them unexpected. Yes, deployed surgery has changed a little bit. You see we are doing remarkably fewer cases afloat now, meaning post-2000, than we were pre-2000. This was an unexpected outcome for us and not a point of our initial investigation, so I could only hypothesize as to reasons, but we also don't think that this tells the whole story. Even though we went down from an average of 111 cases per deployment in the 1990s down to 29 post-2000, which kind of matches up with some of the Army numbers from deployments, We think that the breadth of cases is more telling as to the skill set that the general surgeon needs when they're deployed. So as far as that, no, we really don't think deployed surgery, at least aboard a ship, has changed over the last few years. What we found is the general breadth of cases, the expanse, hasn't really changed. We are proportionally doing discernibly fewer hernias afloat, and so that one in the center is statistically significant. But other than that, we are relatively doing the same general load of cases. So then the second question was, are our general surgery residents who are filling this typically in their first year post-residency graduation, are they ready? Are the two surgeons that are standing there getting ready to go aboard ship and move on? The numbers there on the left-hand side are the same percentages from an earlier slide in those categories. And so we looked at 5 years of graduate surgery logs from our institution and compiled them and compared relevant ACGME defined cases to this. And what we found is, again, reiterating, we are not commenting on the successful completion of the ACGME residency. This is not saying are our residencies preparing people well or not. That was not our point here. But specifically, are our residents seeing the breadth of cases during residency, during training, that they're going to see when they're aboard a carrier in the middle of nowhere? And as you'll see here, for hernias or appendectomies, sure, they're seeing a lot. And these are chief cases. We specifically looked at chief resident cases as a proxy for emerging surgical competency. We couldn't really parse out the fourth year cases where, sure, you may be the trauma chief on the service, and so we understand that. But as a chief resident where you are leading the case, here we are. One thing to call your attention to for appendectomy, we're doing essentially every other resident does one open appendectomy during their chief year. At least that's what they logged. And down for the hand or orthopedics, that is one resident out of the 34 logs that we examined doing one single case as a chief resident that involved a hand or orthopedic procedure. So with those numbers, are our residents ready? Maybe not. They're trained to be good general surgeons, but they may not be getting the exposure that they need to go afloat. A couple limitations. One, and the biggest one or most concern to us, is that there was no centralized Navy or DoD repository for afloat cases. The Joint Trauma System has done a great job with our land-based cases, but if we really want to talk about how are we training people well, we've shown in this assessment that we need a central repository. And can we go ahead one? Thanks. So for our conclusions, the breadth of general surgery, no, we don't think has changed over the last few years. The numbers certainly has, and this is an area for future exploration. And our residents may not be prepared specifically for some of the non-common general surgery cases or uncommon cases not seen in general surgery that they're going to see afloat. So future directions here, some people say, well, we'll just get them to share cases with their urology colleagues while they're in residency. The program directors here may speak to the feasibility or not of that, but we think more likely people doing just-in-time training. There are some models out there. There are simulation centers at all of our major fleet hospitals that can certainly handle some of these cases, because we're not teaching people how to operate. They understand how to do that as general surgeons. We're providing them exposure to cases that they may just not have seen earlier. So they don't need to do 50 scrotal explorations to be prepared to do a single pelvic trauma case, but a little bit of exposure may. And then as the ADAM or ASSET courses are out there, or the emergency war surgery, some of these short courses are available. And having that book on your nightstand in your stateroom, as our earlier talk said, having that book in front of you just to remind you what to do in something that you haven't seen in a few years, creating a deployed Navy Navy surgery book, that would certainly be valuable. So that's the stuff we found as our early needs assessment, and I'd love to take your questions.